The emergence of COVID-19 changed the entire world. We're going to have a look back on one of the most difficult years of public health in modern history, a conversation with Dr. Jeanne Marrazzo. The objectives of this podcast is summarize the key events leading to the COVID-19 pandemic, discuss the missteps and successes of the COVID-19 fight in the US, and comment on the future of what 2021 is going to look like in relation to COVID pandemic. Welcome to Editors in Conversation. This episode is brought to you by the Antimicrobial Agents and Chemotherapy Journal, which is published by the American Society for Microbiology and is available at aac.asm.org. This podcast is the last podcast of the year, and I encourage you to have a look at our latest issue of AAC, which has a fantastic papers on resistance, and the January issue will have a new section that we'll launch called New Perspectives on Antimicrobial Agents. Very good and authoritative review on remdesivir, and we also had a podcast for that. Joining me, I'm very happy to introduce our distinguished guest. Is Dr. Jeanne Marrazzo, who is going to talk about this topic of COVID-19. Dr. Jeanne Marrazzo is the C. Glenn Cobbs Professor in Infectious Diseases and Director of the Division of Infectious Diseases at the University of Alabama in Birmingham. Welcome, Jeanne. It's a pleasure to have you in the podcast.
Cesar, it's really great to be here. I really appreciate you inviting me, and I just want to congratulate you on taking over the leadership of the AAC Journal. You've already brought some really great energy and some creative ideas to it, so it's really exciting to see.
Thank you very much. I also just, on behalf of, I'm sure, all the societies and all my colleagues, want to thank you for your leadership during this difficult year, your continuous messages of facts and truths, and that we can follow. I really appreciate that, and I thank you for that.
You're welcome. I think everybody's been pulling together, and that's your questions when we were emailing about this podcast made me think about, you asked we're going to talk about some of the good things about the year. And I have to say that the way that particularly the infectious disease community has pulled together has been, it's nothing less than I would have expected, yet to see it in action, it's been stunning, actually.
Absolutely incredible. So I remember, Jeanne, in the beginning of the year, I had a meeting here at the School of Public Health and the medical school, and we had a panel of distinguished guests talking about COVID-19 that was being reported in China, none in the United States. And I remember saying that I was very confident that we are in the United States. The infrastructure of public health in the United States was great, that we're prepared, that these things has happened before. 9 months later, we are in this situation. So what happened?
Well, first of all, I'm impressed that you were that optimistic. I think that would have been maybe a hard sell for some people, because I heard a great metaphor recently. I think it was maybe even Mike Sagg, who's been a big spokesperson. He said something like, we were prepared for a pandemic like New Orleans was prepared for a hurricane, and then Katrina came. So, we have this infrastructure that is supposedly ready, but we've all seen now how fragile that really was. My parallel story to yours is that I was at a meeting at the NIH in January of 2020, and it was the inaugural meeting of the NIH-funded Infectious Disease Clinical Research Consortium, which oversees the vaccine treatment and evaluation units. And at that point, we were about a month into hearing about what was going on in Wuhan. And Dr. Fauci got up to address the group of about 70 people. And he said, and we were talking about all the priorities for vaccine and treatment and evaluation units. And he said, and now we've also got this interesting coronavirus that we're hearing about in China. And he said, these viruses, they're bad business. And everybody, the room got really quiet. And it was like, we sort of thought SARS, we thought MERS. But, when Tony Fauci says this is bad business, you sit up and take notice. And boy, was that correct. So we could talk about a lot of ways that things went wrong. I mean, first of all, you have the lack of a coordinated, intelligent, informed, science-based national response. There is no other way to say it. So there was sort of a fit and start national response, but it was characterized by outsized personality issues. It was characterized by misinformation, and I think the hydroxychloroquine debacle and the failure to put that in perspective with the need for an evidence base was really a problem. So I would say that was operative from day one, because even with the initial reluctance from the national leadership to recognize what was happening, even when they did start recognizing it, it was characterized by all this craziness, frankly. The second piece, I think, is that the CDC's initial problems with the diagnostic testing was, I don't want to say fatal to be too dramatic, but honestly, that put everybody in such a horrible position for 6 weeks. I mean, I can remember, as I'm sure you can, back in March and April, when everybody was scrambling to come up with their own diagnostic tests and sequences because we could not get the tests from the CDC. And we were seeing people in February who we know had this infection, almost certainly, and we couldn't get them tested because they didn't fulfill the strict criteria. And then, of course, the tests themselves were not performing well. So I would say in a good year, in a good situation, this would have been challenging. But on top of everything, you had that initial misstep with the diagnostic testing. You had a completely incoherent and at times insensible or nonsensible response from leadership. And then you have a virus, which frankly is pretty unforgiving, right? I mean, it's not like this virus is very easy to prevent ourselves from getting them. We're really seeing the consequences of that now. I'm sure you're seeing people whose only exposures, quote unquote, in this current situation of very high endemic transmission is maybe they just went through town and stopped for a bite to eat, or they got some gas, and or they saw their grandkids. I mean, this virus is unforgiving in terms of how infectious it is. So I'll stop there because I'd love to hear your thoughts. But I think those are the really big features that got us here.
Thank you very much. I was clearly misguided at the beginning, and I'm not ashamed to say it. I was hopeful to do that, but that's somewhere than the situation was. And it's clearly when you see the evidence in front of you, you do change rapidly. And of course, this became very, very clear that this was going to be a real problem. I'm very interested in your opinion, Jeanne, about the countries, particularly neighboring countries with China, that seem to have done this much better than the U.S. with an approach that some people may consider a little bit aggressive, but they actually work in public health. Things like even Vietnam, particularly Taiwan, and incredibly aggressive. South Korea. So where do you see these differences in countries like that, and also emphasize that they may have had more experience than we had on this, but where do you see the difference in these cases?
Yeah, it's a fascinating kind of cultural and scientific and public health contrast, isn't it? So you're right about South Korea. Many of the Asian communities, I mean, if you've traveled through those airports, you've seen people wearing masks. So people were really acculturated, I think, much more to the context of quote unquote, the original Asian flus and the things that people talked about coming out of China early on. So I think mask wearing was a much more acceptable thing there, but that wasn't really true in places that have done a good job like New Zealand, right? Or even Australia to a certain extent. So what else on top of the basic background of acceptability around masks was it? I think it was a consistent and scientifically informed and uniform public health messaging. So we've seen fantastic videos of people who've now become celebrity public health superstars, delivering the kinds of messages that I think we needed from day one. So we needed from day one somebody who was credible, like Dr. Fauci, but could reach out across everywhere, really get out there and get people on the same page. Now, I mean, Americans in general have this incredible individualistic streak, right? We are always fighting for our individual rights and our liberty. And I think the great example was the Supreme Court's recent decision to allow congregations, right, to not put any restrictions. And I know I may not be getting the accurate terms right, but on religious gatherings. Well, I mean, there's always been this tension between public health measures and individual liberties, and tuberculosis probably is the best one. When you still have cases where you've got to go and get somebody who just is a TB infectious person, and you need to put them up in a hotel so that they don't go out and infect people. So we've talked about this in public health for a long time, but this has taken it to an exponentially different level. So when you have the Supreme Court debating about whether it's okay to shut down religious services because the public health authorities are concerned about the transmission of a fatal virus, that says to you we're not in Kansas anymore. And we're certainly not in South Korea, or we're not in Australia, we're not in New Zealand. So I just think that the politicization of everything that's happened has had devastating effects on our ability to communicate consistently what these risks are about. It's created an environment where it's okay to say that this is a hoax. I still get comments, as I'm sure you do, on my social media pages about how we're all making this up. And despite it, another incredibly good thing of this year has been the rise and primacy of scientific journalists who have been amazing at trying to get this message out, even though they've been very good at conveying some of the subtleties and complexities of this. Not everybody's reading them. People are reading what they want. They're going to the sources that are telling them what they want, and what they're hearing has not always been accurate. So I think the reason that control was possible in so many of the countries you mentioned is they've been experienced. They also saw firsthand what was happening in China, and they believed it could happen to them. I think that's the other thing. It's a little related to what you said when you said, oh, we have a great infrastructure here. You're right, we do. There is an attitude, I think, here, and we saw this early in the pandemic when New York was in such bad shape, Seattle was in such bad shape. There is this attitude that it'll never happen to me. It can't. I'm great. I'm fine. I live in a safe part of the country. I live in a safe part of the world. Why should I be upset? Why should I think this can happen here? Why should I curtail my liberties just to make sure it doesn't happen here? Well, it has, and it did. But I think that strain of denial and a failure to realize that I'm just as vulnerable as the next person, whether they live in Manhattan or Seattle or LA, is a definitely American trait.
Wow, fantastic view of this. I just want to go back to the testing situation because, as you mentioned, was one of the critical points at the beginning of the epidemic. And I think one of the things that the other countries did well was try to develop tests and be that accessible, and pull together to do it. And for me, it was really surprising to see the power of the American enterprise and private companies is incredible. If we were willing to put that into putting tests at the beginning of the epidemic, I'm sure we would have done it much better. Mm-hmm. So thinking about this is probably not the last pandemic we are going to experience. Mm-hmm. So what would you think about will be the best thing to do in terms of test developing and that marriage between academic and commercial partners that I think was lacking, and with a big vacuum that prevented us to just get on top of these at early stages?
It's a fantastic question. And when the book is written about this pandemic, I'm sure there will be dozens and dozens of books, but when the book about that is written, I think what people might say is that we misjudged early on how best to approach the urgent need to ramp up diagnostic assay development, right? Because what we did as a society and as a scientific community was to take what had been done previously, which was to get the genetic sequence from China and then have CDC lead the development of diagnostic tests, because this is a public health urgency. This is a public health agency. This was going to be part, I think, of the initial pandemic response. That turned out to be, again, a fatal mistake, because for many reasons. I mean, again, and I think we have to pause and just say that CDC has been doing some of the most incredible work in the epidemic, even though people talk about how challenging it's been for them and how their reputation has been tarnished. I mean, if you go to the CDC website, the resources and the data and the educational materials on that site about what's going on it's astonishing. I would really challenge anybody to go there and not be blown away by how hard CDC scientists have been working. So so I think that, we had this model where CDC is supposed to develop this test and it's supposed to roll it out there in this public health response modality. That already was almost like a decade behind what we needed to do. So you had this sort of creaky, well-intentioned, I think, initial response, but it lacked the kind of rabid urgency that people tend to have when there's an economic incentive, which is how industry is characterized, right? I think the mistake maybe was not realizing that partnering with those industry partners early on, forget about who's making money, honestly, because at that point, we just desperately needed to ramp up diagnostic testing, accurate diagnostic testing. And so I think some very early, again, and this is where if you had a coronavirus leadership team, somebody could have prioritized in February and said, we're going to create this national effort in 3 weeks that would be the diagnosis warp speed equivalent of what they ended up doing for the vaccine development, right? So it would have just taken somebody very early on to say, look, CDC, let's have an honest conversation. How can we help this happen in partnership with our industry people? Now, I'm not in that world, so maybe it would be much harder than I am naively suggesting. But again, if you have a powerful person at the helm who is saying, this is a national priority. I want to test within 3 weeks or 4 weeks. We're going to roll this out. We're going to test it. We're going to know whether it performs. I think you can make that happen. I mean, look what we did with the vaccines. And it wasn't just us, of course. It was obviously our industry partners. So I think that was sort of left to languish early on in a way that ended up putting CDC in a very unenviable position and probably did not need to be that way.
Couldn't agree more with that. Another big topic that I really would love your comments on is about the implementation of therapeutics. And of course, I have again to go back to my experience at the beginning of this, treating patients without really knowing anything what I was doing, and getting mostly my advice from Twitter and other social media outlets with colleagues and friends that were happening in across the pond in Italy and other places. And then I look at this experience with the UK. Of course, they have a single system in which, but the way they were able to deploy clinical trials in a massive scale to keep us informed, that's something that seems to be very difficult to do in the United States. Apart from all these misinformations and missteps and approvals for things that did not have good data, how do you think we can improve in deploying clinical research you have a lot of experience on this in a short period of time, having the same vaccine model and maybe the same template in terms of outcomes and how to implement this research?
Boy, that's a fantastic question. I think back to what you just alluded to, your experience. There was so much desperation early on. Again, we knew that viral pneumonias are talk about a painful consult, right? A viral pneumonia in a young person in the ICU. That's the consult you always hated because what can you do? You really can't do very much. I mean, and we've always been behind that 8 ball. So early on, I think the desperation was exactly as you said. I mean, we were going on Twitter, we were calling people, we were calling our colleagues in Italy, as you mentioned, who were desperately trying to treat some of the people that they were seeing. So what that led to, again, and I keep coming back to this, in the absence of a national response, because not only did the UK have the national health system and that infrastructure to mount the kinds of research that you're talking about, But they also had, and it's a smaller country, of course, so again, not as complicated maybe, although I don't think they'd like to hear that said. Um, they had more of an opportunity to coordinate the approach, and that's how I think you could end up doing something like they did with the recovery trial. On the other hand, it was so bad here that you had people like David Boulware having to crowdsource the funding essentially for his hydroxychloroquine healthcare worker prophylaxis trial, post-exposure prophylaxis trial, right? Because that got no NIH funding. And yet that was the best short-term, reasonably scientifically, hypothetically based intervention that we had at the time. And it was absolutely worth studying. So you got his trial, then, so I mean, he basically, again, early hero of the pandemic, and will continue to probably be a hero. He put that together literally, like with a ridiculously low budget, and it was done beautifully, and it gave us a definitive answer, which is pretty amazing, even with the limitations that they had. You also had other people who were going to the foundations to get money. So the study that was just published in the Annals of Internal Medicine by Rand Barnabas et al. Was funded by Gates. So, you have these smart investigators who know where to go to get funding. They start their trials. And then in the meantime, you've got the NIH, which is designing, of course, the ACT trials with remdesivir, the ACT 1, and now we're up to ACT 5. So again, in some ways, the intellectual ferment and all the creativity was very exciting. On the other hand, it made for a really chaotic landscape. And that, I think, contributed to the communication dysfunction that we had, because people were rightfully asking, well, why is hydroxychloroquine so bad if you're still studying it? You're still talking about it. You're still publishing about it. So again, I think that having had a more coordinated national response, not just the NIH designing the ACT trials, which was, again, an incredible accomplishment. The fact that we are now heading into Act 5, and we've got pretty definitive answers on several intervention studies is fantastic. But again, having this sort of comprehensive approach to how could we really study post-exposure prophylaxis, how could we study inpatient and outpatient therapy. Outpatient therapy, I think, is going to be our really big challenge. Now, not to say we haven't come very far, we have. But I think early on, there was just really, really difficult to coordinate and try to figure this stuff out.
I will be very happy to hear your comments about, NIH had these CTSA networks, the vaccine networks that were created with HIV and other networks. Somehow I think that they might have been underutilized in the early ages of the pandemic.
Mm-hmm.
And do you think that was a case or leadership problems or communication?
Yeah.
With these networks created, I would have thought that we would have a very perfect position to really, launch aggressive clinical trials just from the beginning.
I think it's a great question. And full disclosure, I'm part of the IDCRC, which oversees the VTEs, although we're not a site here at UAB. I think that there are several clinical trial networks that were poised to jump in. Admittedly, some of them had to pretty much shut down their operations for their usual work. For example, the HIV Prevention Trial Network, the HIV Vaccine Trial Network, all of those groups, the AIDS Clinical Trials Group. And they ultimately were repurposed, right, for the study of various interventions. But it took a while. And the COVID Prevention Network, of course, is a consortium of the HIV Vaccine Trial Network and the HIV Prevention Trial Network. They are essentially studying vaccines. So that's what they were going to do. They also were studying monoclonal antibodies. So Regeneron and Eli Lilly. But I think that it took some time for those to get off the ground. And frankly, you had some competition. right? I mean, there were people, I think, who really wanted to run things, wanted to have the oversight. I think that everybody had their hands full again with the federal communication dysfunction. So it wasn't like these agencies were just all sitting together in the same room, problem solving. Maybe they were behind the scenes, but that's not what we were seeing at the ground level. So I think eventually these networks have figured it out. But I think you're right. Early on, there probably were lost opportunities. I think the best example, though, I mean, the ACT trials were mostly VTEU sites as well as some other sites, and they enrolled pretty quickly early on. But I do think that it's one of the lessons learned, that you need to have clinical trials networks, maybe that are a little bit more pluripotent and not disease specific, which is, I know, very heretical because people are very attached to the clinical trial networks as they are structured, as I know you know, and I'm probably going to get a lot of hate mail for saying that. But at some point, you got to sort of say, look, we are not boutique researchers. I am an HIV researcher, but I'm not just an HIV researcher. I mean, we really have to work with what we need. And the urgency of this, I think, has really highlighted it. So I do think that NIH is moving in that direction. I certainly think that, if anything, this pandemic has emphasized how much we need to have a network of sites that are up and running and ready to do this stuff. So preparedness is not something we should take for granted, because that really would have been even more disastrous if we didn't have the network of sites that we did have.
Absolutely. I want to touch another interesting point, to say the least, is the approval process, right? Which is critical in a pandemic, and I think we were not used to this. The word, or the words EUA, became part of the jargon of people. With, of course, like in many other things, people hated that. People justified that use, and both in diagnostics and therapeutics. So what are your thoughts about that process, and how can we do it better?
Yeah, I know. I mean, I guess I knew what an EUA was before the pandemic, but boy, I dream about it now, or I should say I have nightmares. I think the FDA has been placed throughout in a very difficult position. On the one hand, they have an ethical and scientific and public health obligation to get these things out to people as soon as they can to impact what's happening. And I do think that a lot of the decisions were motivated by that desire. On the other hand, it has complicated things immeasurably in terms of moving forward. So you get an EUA for a product that you think is not going to be the be all and the end all. And you know that there are going to be people out there who are going to be using it. There are going to be patients who are demanding it. I just read something today. Someone wrote on the Idea Exchange about being presented by a family's demands for a patient who was in the hospital, and the family wanted to be sure that the patient was on everything from hydroxychloroquine to zinc to all of the other quote unquote putative or hypothetical therapies that have been bandied about in this pandemic. So you create a situation where you normalize the potential for products or interventions that you or I might not think is absolutely the best thing for that patient, and in fact might even be harmful. But it becomes very difficult to discuss that level of complexity and subtlety with families who are desperate too, and who are seeing their loved ones so sick and dying. So it's created a really hard, I would say, situation on that level. The other really big thing is, of course, trying to research next generation products, right? So if you're really trying to figure out whether a monoclonal antibody is better than something that already has an EUA, or a diagnostic test for that matter, although that's a little bit less complicated. How do you do that and make sure that you are getting the most accurate assessment of this new therapeutic? So, and I guess the big overall thing I worry about with the EUAs is does it undermine people's trust in the process? Because do you feel confident enough that the data that went into that evaluation and the analysis of that data was really rigorous? Or are the decisions being made so quickly that you really can't trust them quite as much? I trust the FDA's process. I think they're generally very, very, very good. But I think the pressures here have really brought a lot of those questions to the forefront and made it hard again for us to talk about these things.
And also, I think, for example, that could influence a lot of the clinical research doing, because people are not going to continue studying this when they have to receive these EUA's approvals. And I think the story of convalescent plasma, for example, is one of those that we still don't know really how much efficacy that is, and it has been something that we could have studied very well from the beginning.
Absolutely, yeah, and that's probably one of the best examples when that got the EUA, because people were generally like, really, that does not make sense based on the data that we have seen. I would say most of us would say that. I think some people would argue for it. On the other hand, I don't think any of us would argue against studying it rigorously, which now we are doing, but has become much more complicated.
So I want to move now to more positive things. I really would like to try to end in a very positive note. One of the things that I liked your opinion is about how clinical microbiology and infectious diseases became such a forefront specialty and field, and how the most famous doctor in the United States now is an infectious disease doctor. And people sometimes do not understand or did not understand very well our role. And I think the role that we've been playing, and people like you have been playing, are been incredible in this among this chaos. So how do you see this for the specialty for us?
Well, I think ID doctors are quintessential stewards, right? Trying to keep everybody safe, often in the background. So the only time you might see an infectious disease doctor in the hospital is if you get into a lot of trouble with an infection. But people don't realize that we do so much more behind the scenes to make sure that you don't get an infection in the first place, whether that is working on preventive therapies like vaccines, whether it is developing new drugs and testing them like you do, in case people get infections, and particularly really bad infections, or whether it's just through infection prevention practices that people use in the hospital and stewardship. So, we're like the little quiet bots in the background that really have not necessarily had our big day in the sun. If anything, this has illustrated that, and then more, right? So it's kind of like, you don't just need us when there's an emergency, you really need us to keep things safe all the time. I think the other thing I would say about the pandemic is that I don't think we've heard enough about yet. And I think, Cesar, you are in a unique position to start beating the drum about, and to probably highlight on a podcast coming up, which you're probably thinking about this, is reminding people that these COVID hospital stays are no picnic, and they are not short. So we have a lot of people, as you, I'm sure, did too, who've been in the hospital for a really long time with COVID. And I would say most of our non-COVID infectious disease consults right now are for complications of those hospitalizations, of which a substantial proportion are antimicrobial resistant organisms. And I just saw the MMWR, which you can probably comment on more intelligently, about it was a carbapenem resistant enterobacteriaceae. I can't remember exactly what it was. Yeah, in a hospital associated with the COVID ward, and we are absolutely seeing skyrocketing infections in the hospital because of these things. I think there's a couple of things that are going on there. I think the antibiotic overusage is unbelievable. So people come into the hospital with COVID, they come to our COVID clinic, all of them are on antibiotics, and they're almost always on azithromycin, and sometimes they're also on another antibiotic like augmentin or cephalosporin. It's insane. And then all of them are on steroids, which gets back to our challenge with studying some of the interventions, because that often will eliminate them. So antibiotic overuse is huge. I think we're going to just see the echoes of that coming down the pike in the next months. And then we're not examining people the way that we used to, right? So I think this whole isolation thing, you would think it would make it better in terms of transmission, but I don't think that we are necessarily seeing the same sorts of interactions with examining patients and perhaps even doing some other basic tasks. So I'm really worried about that, plus the prolonged hospital stays, the intubations, the respiratory stuff. I think we're going to see a mini epidemic, hopefully not a pandemic, a mini epidemic of a lot of these problems. And that's going to come back to what you do so well, which is advocate for the development of and judicious use of antibiotics.
Fantastic points that you make. There's definitely, we've seen this all over the country, and I know very, very much people reporting really superbugs emerging all over the place. Jeanne, let's talk about vaccines. I think this, if anything, I am really amazed was the stories of the development of these vaccines. And particularly vaccine that have never been used in humans. And we are now putting them in humans at a larger scale. Yesterday, the UK announced the first starting of mass vaccination, which had never happened in modern history until now. That's probably a silver lining. And one wonders if that model could be applied to the therapeutics area, diagnostic area. And so why don't you explain our audience a little bit, what was the key factors for the success of these vaccines?
Yeah, it's a fantastic question, because if we could bring to bear the scientific force and commitment and power that have been brought to bear to the development of the COVID vaccines, we could probably conquer anything. I mean, it is really a remarkable achievement. There was a great article in the Washington Post just this past weekend, I think it was by Carolyn Johnson, that described how the stage had been set for mRNA vaccines in particular, really over the last decade. I mean, there have been people working on messenger RNA for a long time, and I know it's notoriously hard to work with. It's very unstable, as I know you know. And so there were a lot of people who were toying with it and trying to figure out how it could be the perfect sort of little messenger, literally, for a protein factory to make antibiotics. And antibodies, sorry. I think the development of the vehicle, the nanoparticles, or the lipid nanoparticles that deliver this very fragile sort of element to the cells that you're going to try to get pump out the antibodies, and that actually happened well before this pandemic, right? So people were developing this for other viruses. I think Nipah virus was one of the early ones. So I think people need to recognize that one of the reasons we have gone so fast isn't because we all of a sudden decided that investing in vaccine infrastructure and research was good. You have the Vaccine Research Center at the NIH, run by very committed people who have been thinking about this for a long time. A lot of it funded by efforts to create an HIV vaccine. In fact, I believe it started under President Bill Clinton around this effort to power up the HIV vaccine initiatives. But that center has been, moving along in parallel with all the HIV vaccine work, all of these technologies, all these platforms, the SARS epidemic, the Ebola epidemic, all of these things really allowed for preparing for this moment. So it's one of the nice things. I really think we have to remind people, this is not just because Moderna and Pfizer and all of these companies just all of a sudden decided to get together and do this. That was a big part of it, but they were riding on the back of a horse that has been really taken well care of and has been grown up in this system that we can't afford to not acknowledge. So that's just been really incredibly exciting. I think the question of mRNA vaccines, I don't think anybody expected this wildly effective result. This 95% is like almost too good to be true, right? I think that the issues are going to be safety, longer term safety, and how are we going to address vaccine hesitancy on top, which was already, I should say, which is already below the surface. And then on top of that, you've got all the mistrust around COVID that we've talked about. And you've got the fact that, of course, underrepresented minorities, particularly people of color, have been hugely disproportionately affected by the mortality and morbidity of this virus. And yet that may be a group that may need the most, I don't want to say persuasion, but education, discussion about mistrust. And so I think, yes, really exciting results, but we have a lot of work to do to get those people and ourselves and all of us vaccinated.
Fantastic. Just to finish, I'm going to ask you to see your crystal ball for 2021. And 2020 is ending in a really bad shape. Infections going up, mortality. People seem to forget that we are in the worst part of the pandemic. It seems like it. Then on the other hand, we have these vaccines coming up. So how 2021 is going to look like for you, Jeanne?
Well, I know you know this, and I wish I didn't have to say it, but we all know it's going to get worse before it gets better. The vaccine is like a white knight coming in, but the soldiers are already dying on the battlefield, and the battle's still going on. And I think the timing is so worrisome because we're just now seeing the big brunt of the Thanksgiving holiday, unfortunately, right? And we're seeing that heading into the Christmas holidays and the end of the year holidays that many people celebrate. So, we just looked at, as I'm sure you have been doing, statewide forecasting for hospitalizations today, and it looks really bad. And it's looking bad a lot of places. Those people are not going to be helped by a vaccine. My only hope for the vaccine, and we're supposed to get our first doses here next week, is that we can start vaccinating the people who are coming in contact with those patients, healthcare workers, and we can at least stem those infections for those people. We have a lot of people out of work right now. It's not just hospital beds, as I know you know, it's also the workforce. So how do we continue to take care of people, also ensure that we have a workforce? We've got to get healthcare workers vaccinated like yesterday. So that can't come soon enough. So I think there's going to be a period of significant pain in January, probably into February. If you think about the timing of exposure over Christmas, if people continue to not be as rigorous about some of these precautions we've been talking about. Assuming we can ramp up vaccine delivery, assuming that Moderna and Pfizer really ramp up the numbers that they've been talking about, we might get a good chunk of people immunized by the spring, right? So that would be the goal. Could you start seeing an effect of herd immunity? It depends. I think the models say that you need to vaccinate or you need to have protective antibody in about 60-70% of people. That's a lot of people. The good thing is we will be heading into the spring, so we will not be, in our houses the way that we have been in the Northern Hemisphere, and part of the reason I think this winter is being so bad right now. So, I guess my best predictions are it's going to get worse before it gets better, and then it's going to slowly get better in the spring. Then the question is going to be, what's the duration of protection of the antibody? So I'm sure you saw the New England Journal letter that just came out December 3rd, looking at 3-month persistence of antibody with the Moderna vaccine, and it looked great. It looked good in all age groups, across all subsets. Now, 3 months is great, but we need something to be effective for at least a year, or 9 months perhaps, to give us a breather, right, to get a reset. And then we're going to have to think about, do we need to revaccinate people and what's that going to look like? So all that to say, there's a lot of work to do, but there's also an incredibly robust research opportunity because we don't know anything about yet. We're learning, but this whole concept of revaccination, is the vaccine, what are escape infections going to look like? What about people who get vaccinated and then you do see them get infected? Is that a different virus? We're going to want to isolate that virus. We're going to want to reverse engineer, the usual approach to it. So just a huge amount of things to think about. The final thing I would say is, and I mentioned this before, Cesar, outpatient management of infection. We have monoclonal antibodies. We know they work. One of the hardest things about managing this damn infection is the timing, right? So we know that if you don't give that monoclonal antibody probably in the first week of illness, it really isn't doing very much. Similar to remdesivir, how do you prioritize people in the outpatient clinic? You want to keep people from getting hospitalized, but you also don't want to wait until they're so sick that they look like they really need an intervention. So we've been struggling with that a lot. And I think as we get more, hopefully, monoclonal antibodies, very limited supply right now, maybe we can ramp that up, and maybe that will also impact our hospitalization rates early in January or February. One can only hope.
Jeanne, again, thank you very much for your wise words, clarity in this pandemic and and chaos that we had in 2020. I hope you continue doing this wonderful job in 2021 and lead us to a better future. I really appreciate you participating in the podcast. This is Cesar Arias, Editor-in-Chief of AAC, signing off. Thank you very much.